All right, that's awesome. Um, well, let's go ahead and get started. Hi, everyone. We appreciate every single one of you for finding time and energy to joining us for this webinar of all you ever wanted to know about abdominal wall fellowships. This webinar was brought to you by Resident and Fellow Committee of American Hernia Society. So we decided to stream this webinar ahead of our AHS annual meeting in Nashville for future applicants so they can network with leaders in the field on leadership and trainee reception and distinguish yourself at Hernia Olympics and Jeopardy. Plus, you guys will be better prepared perhaps for your applications in December. So today we are joined by two recent AWR Fellowship graduates, Drs. Andrew Sabur and our committee chair, Dr. Benjamin Fong. And we're also super excited to have two AWR program directors, Dr. Kayla Blake and Igor Belyansky, who will share their insights and experience with selection process, whether it's through the Fellowship Council or outside of MIS match. So I'll go ahead and briefly introduce you all. So Dr. Sabur, he just completed MIS Fellowship at Prisma Health at South Carolina in Greenville under Drs. Carbonell and Cobb, and he's currently a minimally invasive and bariatric surgeon at the University of Nevada, Las Vegas. Dr. Fang, whom I know for a few years now, graduated from AWR Fellowship at Penn State under Dr. Eric Polai and started practice as a general and abdominal wall surgeon at New York General Hospital, University of Toronto. Dr. Blake is an assistant professor of surgery and AWR program director at University of Tennessee, Knoxville. She completed two fellowships, MIS at Dartmouth-Hitchcock and AWR fellowship at Cleveland Clinic, Ohio. And Dr. Belyansky, of course, doesn't need introductions. He's an abdominal wall reconstruction surgeon and chief of general surgery at Anne Arundel Medical Center and AWR Fellowship Program Director. He's a graduate of Hannaford Fellowship at Carolinas. So we can wait a few more minutes. This discussion will be pretty interactive. So we're going to give the podium to our panelists to discuss their advices and experiences with whether it is application process or really finding your way in this MIS territory, and of course sharing their insights as program directors. So we probably can wait a few more minutes. We also have a few questions submitted online ahead of webinar, and we're going to run the interactive Q&A session here, so you guys can go ahead and send us any questions that you feel worth discussion.
And maybe we could get an introduction of the people who are joining us today and what year you are in residency and what you're looking for in a fellowship. That'd be helpful in the chat to see what you guys are looking for.
Excellent idea. Yep.
We can also chat amongst ourselves and just, I'd love to hear how you guys decide to become AWR specialist,
Yeah, well, I'm gonna get started, I guess, real quick. So the reason why I came to this business is because of you, and you know that very well. So the way it happened, I realized at the end of my third year that I really like MIS, but I really didn't know because I was speaking to Dr. Averbach and some of our general surgeons in my residency program, and the exposure to ABWOL was pretty minimal. And hi Diego. It was really difficult because I applied kind of everywhere as an IMG, so I can probably share my experience as IMG. So back then I was on visa, but I just recently got my green card approved through EB2 process, and then I applied everywhere because I didn't know if I'm going to get any interviews. I mean, my site scores were fine. I had some publications, but it was not like stellar, I guess. So then I started to get invites. I started to interviews. I got like 40 invites. I got sick of myself, and then I came to Igor. He hosted me for a month, and basically, when I saw what he can do on the robot, I said, this. And I don't want to do with anything else. I like to do reconstruction and recreate normal anatomy and not just cutting things out or alter normal anatomy. And at that point, it was pretty clear. And basically, I really switched to hernias, and I'm absolutely happy. So it's my small story.
Yeah, mine's similar, Dr. Belyansky. I saw some of your videos when I was a resident and I was like, that looks like magic and I want to figure out how to do that. So honestly, you're the gateway into all of this because you like it was awesome because we could search and see something, it's hard to find ABWAL fellowships, especially I was, looking 5 years ago, and especially like 5 years ago, there's nothing in the fellowship council. So yeah, I found your videos, and then it wasn't until my chief year that I figured out there were like dedicated ABWAL fellowships, and I could actually like be a specialist at this. So my chief year is when I started interviewing, and luckily got to go join the Cleveland Clinic group and learn from them for a year. And so now I've been out for 3 years, and we just hired a partner that's also from Cleveland Clinic. So now there's two of us in Knoxville, and we just started a fellowship. We're in our first year of the fellowship council for at our program. But yeah. How did you
Congratulations.
get onto it?
Me?
Yes.
I mean, I'd love to hear what can we hear about Andrew and Ben first? Is that okay? I'll tell you the whole story. I might be long-winded.
We'll save the best for last.
Yeah.
I had a family member who had a loss of domain hernia, and I always knew I wanted to do it in general surgery. And then in training, Canada is a wonderful place to train doing general surgery, but a pretty probably like 10, 20 years behind in terms of the state of hernia reconstruction, certainly at the time that I was doing my training. And so I wanted to do it, and I had no idea how to do it. And even, 2 years ago or 3 years ago, 2 or 3 years ago, when I was applying, ABWAL fellowships were just becoming a thing in the US and were completely unheard of in Canada. But I had some really good mentors. I learned about this whole world in like a month, and then I took a big gamble and said I'm going to go all in and dive into it. Applied to every program, got rejected from all but three, didn't even get an interview from all but three, and managed to snag a spot, and I feel incredibly grateful. And since then, it's been the most wild but best ride of my life. I'm really enjoying it so far.
That's awesome. It's great.
Mine's
Andrew.
mine's kind of unique. So I think in surgery in general, 10 years ago, nobody would have picked abdominal wall recon. I think surgery is one of the unique fields where it's kind of an apprenticeship and you find a good mentor and you kind of want to copy that mentor or be like them. And that's kind of what leads you down there. So I was actually going to be on the surgical oncology road for most of my residency because my mentor, who I'm now working for, by the way, in my full-time job, the chief of surgery, St. Hill. He's a surgical oncologist. But then in residency, and the reason why I wanted to be a surgical oncologist was because I felt like they were the best type of general surgeons. They were really an artist of the craft. They weren't just like a trauma surgeon who just focused on saving a patient. They knew the patient before and after and families. But then around fourth year in residency, I started realizing that not only the lifestyle surgical oncology, but the deficiency of people who would come into the Las Vegas ER with big hernias, and we would have no idea what to do with them, and we would send them to UCLA or Mayo in Phoenix or even Cleveland Clinic. We had no idea what to do with them, and in my mind, I was like, well, if I want to be a good general surgeon, I need to know how to fix these problems. I need to know how to fix anything that walks in through the ER door that's within my realm, which to me it's the abdomen. So that's why I ended up doing a minimally invasive surgery fellowship with foregut, bariatrics, and ab wall because I want to know how to do it all and to do it at a sophisticated level, like at a finesse level. And so I ended up doing that. And then during my fellowship, I really fell in love with working with Dr. Carbonell and Dr. Warren. They're just two of my favorite dudes. And so I just picked their brain the whole year. And I was like, you know what? I think I'm going to focus more on this more than the bariatric stuff. So that's why I ended up doing more. My specialty now is basically hernia and foregut. And I'm kind of leaving bariatrics in the back. But that's kind of how I went into fellowship. I wanted to be broad and be the master of all trades. And that's kind of how I narrowed myself into Abwal.
That's great, Andrew. Andrew, what year did you finish?
What year? I just finished last month.
I just finished.
I just
Okay,
graduated.
Very cool.
So.
Listen, guys, this is surreal realizing that I am the most senior guy here by essentially 10 years at least. That's crazy. So listen, first of all, thank you for inviting me, and this is great that we're doing this. The AWR fellowship is I feel like coming very fast a long way. I finished my residency 2010, and I did a 2-year fellowship with a guy named Todd Hannaford. And at the time, Dr. Hannaford was at Carolinas Medical Center. And when true story, well, I'm going to tell you is a true story. I had no idea, that I wanted to do like AWR. I knew there was some fancy hernia repairs at the time, but there was not, back in 2010, there was not much there. If you start looking at literature, the fancy stuff we used to do was endoscopic external oblique releases, and together with IPOM meshes placement. So when I interviewed at Carolinas Medical Center, I applied there. This is a true story because my mentor at the time was doing CSAP questions, and he was looking at the questions, and the name Todd Hannaford kept popping up. And as I was applying with my mentor, he is like, and I'm from Baltimore, Maryland. That's where I did my residency. And he's like, why don't you go ahead and apply there? I keep seeing this guy's name at CSAP. It'd be interesting. I want to hear what you have to say. So I had no idea it was a 2-year fellowship. I submit my application. I get an interview, and the first thing I find out, it's a 2-year fellowship. And I'm like, I had zero interest at the time in research. I'm like, there's no way I'm going to be ranking this. So I'm looking at the doors, thinking how I'm going to sneak out, And then Todd Hannaford walks in, and with Dr. Hannaford, he is a very incredible person. And if you ever hear him speak or talk, he can really light up the room. He can really palpate the energy sometimes. And we just hit it off, slightly similar personalities. And when I drove back home, or actually flew back home, I told my wife, I think I'm going to do a 2-year fellowship. And she's like, are you crazy? She's like, you don't want to do any research. I'm like, I think I'm willing to do a year of research to work with this guy. And again, I had no idea that I'm applying for a hernia fellowship. I was applying for MIS fellowship. So this is some of the things we can talk about, how things have changed, because back in the day, it was an MIS fellowship meant so many different things. Like Andrew said, it could be bariatrics. It could be bariatrics, AWR, and the MIS. MIS, could be inguinal hernias, it could be IPOM meshes, it could be right colon, left colon for benign disease, sometimes malignant disease. I mean, it really depends. It's anything through small incisions was MIS. It dates way back to 30 years ago when Fellowship Council was started, actually started by one of my mentors, Adrian Park. He was one of the people who started it. Interesting story about Fellowship Council, as a side note, was why it was started. But anyways, back then, laparoscopic surgery was brand new, and there was no robotic surgery yet. So anyways, to fast forward to my fellowship, so I very quickly realized that Todd Hannaford was incredibly well known around the world as a hernia surgeon. At the time, we mostly were doing open AWRs, and at the same time, we were doing inguinal hernias, and for MIS stuff, we were doing laparoscopic IPOMs. That's as fancy as we got laparoscopically. And so, and what you have to realize if you're going into this, it's really Todd Hannaford's name and his disciples is really they're really heavily dominating the field. So names like Will Kopp and Alfie Carbonell, which is mentioned by Andrew, they were both trained by Todd Hannaford, except they're slightly older than I am. Names like Yuri Nowitzki, who trained Artyom here, is again one of the disciples of Todd Hannaford. Yuri actually was in a paper back in 2005 describing the first open preperitoneal repair, which really laid the foundation for what we call TAR now, for transverse abdominis muscle release, which is essentially a repair where we do what we call posterior component separation to create a visceral sac, which is based on technique that Todd was doing, and Todd was just peeling the peritoneum. So if you think about this, it's so cool. And so there's a history of the last 20 years how this has evolved. In 2000 and around 2000, I think 9 or 2010, Conrad Ballester got trained by Alfie Carbonell, and Conrad was crazy about robot. I don't think Alfie liked the robot at the time. Conrad left, and he ended up doing a first robotic case, and he actually did the first what we now call a Carbonell repair. Maybe Andrew would know what Carbonell repair is, but it's actually was the first paper of actually Alfred Carbonell coined the term posterior component separation. But posterior component separation, what the way Alfie meant was he actually was dissecting between internal oblique muscle and transversus abdominis muscle. What we do now when we do a call a TAR, we actually stay medial to linea simularis inside 2 layers, posterior lamellar internal oblique and transversus abdominis muscle contributions, and get to the space superficial transversalis fascia, and we're right behind transversus abdominis muscle. So 1 level below. But Conrad was the first one who ended up doing robotic robotic posterior component separation, which is conventional repair, and then he got Alfie to do robotics. And so, but Alfie at the time was already well known. He is actually a great speaker. Unfortunately, he doesn't speak as much in public anymore. He's an incredible speaker, and so what he ended up doing is what he became known. Alfie became known as the first one, even though Conrad was the first one who actually from the stage started talking about robotic transverse abdominis muscle releases. And all of us back in 2013, 14, we're kind of like giving Alfie a hard time because we were saying, "Oh, we can do a TAR in 2.5, 3 hours," and here Alfie is doing a 6-hour robotic TAR. So like, it's so funny. He should be laughing at us right now that all of us are doing robotic TARs. So just want to give you, the field has changed incredibly. The field is really now like, can you define it as MIS? You can't really define it as MIS. Like really has the AWR field has components of general surgery. Still very important to be a good general surgeon. Plastic surgery, if you're doing open cases, you either partner with plastic surgeons or you have to understand how to do at least the basic plastic surgery. And then what am I missing here? Hold on a second. Plastic surgery. Hernia repair. What is hernia repair? Like kind of in a way, hernia repair. Like we always think about like just patching holes. But this whole understanding, evolution of how we talk about kind of downwall has changed as well. There's so much we're going to be talking about sometimes in fellowship that I'm like, listen, I think this is right, but we have to show that it's right. For example, talking about function, what improves function, what's good, what's bad, what is appropriate tension of the abdominal wall? How do you measure it? We don't have a way to measure, what is the function of the abdominal wall. We still have not come up with it. There's so many things to really look into a study, but it's incredible how this field has evolved and will continue to evolve. And there's so much, those of you who are interested in going, there's so much, but if you're interested in academia, there's so much to study, so much to learn still, and so much to kind of really report back. I don't know, I'll just get off my soapbox here and let you guys speak. That's it.
Igor, that was incredible. Thank you so much, for sharing this really historical tool for us. So, I just want to echo you that the field is certainly evolving. And although we did celebrate 10 years of Robotar, for example, but as you said, there's still so many things that we don't know. All the computation models are still very, primitive, and we don't have even a lot of basic science data is lacking, right? Properties of human tissues themselves. Again, we don't have a good personalized approach for hernia repairs, As and Yuri says, good tire never hurt anyone, and he's definitely right about it. But at the same time, we see now new approaches like TAPRA, right, coming up, and we are still, looks like the history is a little bit spiraling, and we're perhaps going to be again in the preperitoneal space, more or less, for most of the time. Let's go ahead and pass the mic to. Well, since you started, we can probably let's actually go ahead and see what Ben and Andrew think about their recent perspective, because this is something that, again, obviously, when you were applying the Hannaford's Fellowship, it was very different landscape than now. So, what challenges did you guys see? How did you find yourself? How you were able to distinguish yourself? What do you think is the most valuable advice that you can give to the applicants nowadays?
Yeah, thanks, Artem. I think I'll pull up my presentation, like my very brief presentation, and I'll hand it off to Andrew. I'll talk to you guys a little bit about like what I wish I knew at the time when I applied for my fellowship and what my fellowship was like. So I'll quickly share my screen. Okay. If anybody cannot see my screen, just let me know. I'll quickly just tell you folks introduce myself, tell you folks about my background, and what I wish I knew at the time that I was applying for AWR fellowships at the stage that you guys were all at. So this
Ben,
is my
you are
journey.
sorry, you are in presenter mode. I think it's totally
Oh,
fine.
I
We still
see.
can see that, but
You're seeing the wrong screen. You got it. Okay, give me 2 seconds. Thanks, Artem. That's a rookie move. Here we go. That looks better, right? Excellent. All right, stop me if I'm sharing the wrong screen. I'll quickly tell you guys about my journey. I am from Canada, and so if anybody has any questions about what it's like to apply for Canada or apply as an IMG, I'm happy to talk a little bit about that. And Artem can fill in his blanks in terms of his experiences applying as an IMG. But I originally am from Toronto. I finished my undergraduate at McGill, medical degree in Toronto, and then I finished my general surgery residency in Ottawa. You folks heard a little bit earlier about why I got into ABWA. I was wanting to become an ABWA leader in Canada, change the landscape here, bring all the innovation and all that history that Dr. Belyansky was talking about to a place that has more than enough of its share of hernias and a place that was starving for innovation and leadership. And so I wanted to really bring all these skills back to Canada. I applied out of the blue and got very little interviews. I ended up getting interviews to 3 programs, and then was lucky enough to get accepted at Penn State for an ABWA fellowship there with Dr. Eric Pauli. It was an incredibly productive year. In the year that I spent there this past year, I finished 572 procedures. Of those, it was 365 hernias, a pretty equal split between robotic and open. And along the way, I entered the program really wanting to become an ABWA specialist, and that's what I was interested in. I told myself I would never do bariatrics again. But along the way, I picked up a lot of things that I was, turned out to be very interesting. Dr. Pauli and the other folks there, Dr. Josh Winder, they're experts in flexible endoscopy. And now I'm happy to say that I picked up a lot of those skills, and I spent a lot of time in my interviews talking about that, and will be doing a lot of that in my practice. And in that fellowship, I was exposed to my fair share of foregut and bariatrics, things I might not be doing in my practice, but I will certainly be seeing on call belonging to an MIS division, and I'm happy to do so. It was absolutely the best year of my life from a professional training sense. And then now I've come back to Canada at the University of Toronto at North York General Hospital, where my practice is going to be about 80% hernia, 10% flexible endoscopy and MIS stuff, and then some acute care surgery. It's mainly it's a large academic affiliated community hospital, so I'm mainly doing clinical work with some academic stuff, mainly teaching residents and hopefully fellows in the near future. I'll try to keep it short to say here, these are the things I wish I knew when I were in your shoes applying for an abdominal wall fellowship. I think it's so important to know exactly what you want and just be very upfront with it. It is okay for you to be someone who wants to dabble in a bit of hernia and then maintain a very broad practice of MIS, bariatrics, foregut. Or if you want to be someone who's doing pure complex ab wall and you never want to see bariatric surgery again. It's okay for you to be wanting a community center and just doing tons of clinical work and not want to do academics, or vice versa. Being very clear with what you want allows programs to say, hey, this is the right person for us, and so that we are the right program for them, and things have a way of working themselves out. The folks that I saw who were most unhappy were the ones who were unclear about what they wanted or dishonest with what they wanted, and showed up, or didn't get accepted because program directors can see through that, or showed up and didn't get what they wanted and left the program unhappy. So be very clear. And I went into my fellowship knowing that I wanted to work with Dr. Eric Pauli. I wanted to work with the other folks who did complex hernias. I wanted to really learn not only how to be an excellent clinical hernia surgeon, but also to be a hernia leader in terms of the leadership skills, the administrative skills, the partnering with industry, the research skills, and all that stuff. And I got all of that, all I wanted. I think another really helpful question is to when you're thinking about programs and whether or not that program is going to be the right program for you. I'm going to move this out of the way. is to ask where those graduates are now. It really is a good measure of the success of a program. And when you're able to see, hey, where are the people who graduated from this fellowship? Where are they now? Did they get to the places they wanted to go? And are those the places I want to go? It really shows whether or not it's going to be the right mentorship, right fellowship program for you. This is a picture of some of the recent graduates from Penn State. You've got folks like Toria Rendell, Ryan Yuza, Sal Dosimo, along with some other fellows with me. And not only are they, extremely successful in their own right, but now I've sort of joined a family of folks who've graduated from this fellowship, folks who sort of welcomed me to the family, and I can call them out of nowhere. They've never worked with me before, but they know that I was a Penn State fellow, and they're happy to work with me or partner with me and help me out. And I think that's pretty wonderful. When you're thinking about a fellowship program, I encourage you all to think beyond the OR. What are the other things that you want to learn aside from being an excellent hernia surgeon? Does the program support you to go on courses? Do they have CME? Are they attending conferences? And are they giving you the opportunities to participate in research and publications and book chapters? Are they introducing you to things like what working with industry is like? I didn't think about any of these things. 2 months before I started my fellowship, Dr. Paula emailed me and said, hey, I think you should work on this book chapter and it's going to be really helpful. And, it was. The opportunities like this are so important in your professional development when you're applying for jobs and in the future. And it's not just in an academic setting if you're pursuing that, it's also in any other sort of job description. And choosing the right fellowship that matches with what you want is so helpful. Finally, I think that this is more advice once you get into your fellowship to take full advantage of it. So as much as I'm saying, like, I came into this fellowship knowing I only wanted to do hernia and that's what I wanted to do, inevitably we all end up falling under some sort of MIS division, and it's very likely that you're going to be doing some sort of emergency foregut, emergency bariatrics, emergency MIS, or even ACS call. And so once you're in there, learn from all the faculty members, take notes on everything, make the most out of every learning opportunity and every operative opportunity. And more so, you might even discover something that you didn't know you liked and would become a big part of your career. Whether that for me is something like flexible endoscopy, or here, a lot of endoscopic CBD exploration, endoscopic biliary interventions is something I picked up, and that's a picture of us doing that. Or even Andrew talking a little bit about his experience of going in wanting to be broad and now, specializing or narrowing a little bit more into hernia. So, life is full of surprises, as Dr. Belyansky has explained. And if you go in with an open mind and take full advantage of every learning opportunity, it only come back in dividends. I'll just put a shout and plug in for something that our committee has been working on. Everyone applying for an AWR fellowship ends up with something like this. You create an Excel document, you try to find all the different fellowship programs that are out there. And as Dr. Belyansky will tell you, fellowship programs used to be by word of mouth, unofficial things. You couldn't find the central place. The Fellowship Council came in a number of years ago, and then last year made AWR an official subspecialty in a subcategory of fellowship programs. And now the American Hernia Society has collected as many both Fellowship Council and a non-Fellowship Council independent hernia fellowship programs into a single directory, so that you don't have to make your own spreadsheets anymore. We've tried to compile the most important information and also link to these programs. At the bottom of this website, which Artem has linked in the chat, you also have a lot of advice from our committee about what you should be looking for and thinking about when you're applying to these fellowships. So yeah, that's what I wish I learned at your stage. I'm happy to answer any questions about what it's like to be a grad of a dedicated ABWAL fellowship, and also what it's like to apply as an ING.
Ben, thanks. Thank you so much. That was awesome. I think one of the most important things that I personally took from your talk is that you emphasized how important it is to be candid with yourself and really figure out what you want. Because if you realize that some case mix, even disease pathology, even region where you practice, because it all comes with a certain, population, right? Population of Manhattan, patients who come to Nowitzki is different than Cleveland Clinic population in Ohio, of course, right? So you need to think about all that stuff. And if you have a mismatch of what you're going to get in your fellowship versus what you're expecting, there always will be some frustration, right? And some misunderstandings. So you need to really to figure out what you want and just really make sure that when you rank those programs is that you rank them according to what you want. So IMG discussions about issues and challenges unique challenges that IMGs have. I think it's a very important question actually, because we do have a bunch of those in our pre-webinar Q&A. So personally, I'm just going to put my 2 cents. I wouldn't apply to fellowship at all if I would be on the H visa, right? And obviously, a lot of folks who are IMGs, ACFMG accredited, they are either on J visas, right? Or if they're lucky enough, then they will be on H1. And from what I can tell you is that it's really, really difficult to find a fellowship that will sponsor any kind of extension for J visa, or especially that will sponsor you H1. So I wouldn't be applying for fellowship at all if I wouldn't get a green card by that time. Actually, I didn't get a green card. I actually had just the petition approved and work authorization. So I did notice when I was applying myself that a good half, perhaps, of programs, at least in MIS category, broad spectrum MIS, they wouldn't accept international grads. They would accept only American grads. So that's something that I have noticed. I'm not sure if things has changed, but that's again just something that we have to deal with. So can you tell us about your struggles with it?
Yeah, I would say that applying as someone not trained or in the US was super challenging, no doubt. And it wasn't terrible when I applied, and unfortunately, with the current political climate, it has gotten worse. When we compiled this list and directory, we've noticed that the number of programs that advertise that they sponsor a J1 or H1B has substantially decreased. I would say before it was about 30 to 40% of programs, and now it's 25 to 20% of programs, which again just reflects the challenges of visas and the investment that each institution has to make. I would say points of encouragement is all the paperwork and all the listing and all the declarations is just lip service. At the end of the day, there are exceptions to every rule, and I would encourage everyone to still apply and directly reach out to these programs and be honest and be direct and say, this is my situation, this is who I am, this is my narrative, this is what I really want to do. I had emailed every single program director saying that I had not finished my steps. Like I never knew that I wanted to do an American fellowship, and I knew that I would be automatically disregarded if I didn't have my steps completed. I emailed every program director and said, I don't have my steps, I'm a Canadian applicant, this is the situation I'm in, and I really want to apply. I also emailed every program director and their admin who said, we don't take Canadians. And I said, I know you don't take Canadians, just please, like, I'd love to meet with you. I'd love to just chat with you, hear me out. This is the situation of who I am and what the Canadian situation is like. Would you ever consider it? A lot of people still rejected me. I still didn't get a lot of interviews. But I remember a number of excellent programs that still said, I know our policy is that we don't take this, but we're still going to interview you anyway. We're going to take a chance. We'll see. And no promises were made at the end of the day. But in speaking to program directors since then, and we've heard many situations where folks were able to get their H1Bs or J1s sponsored anyway. Folks ignored the fact that I didn't have my steps and gave me a chance to finish my steps before I started the program. And so I would say for all folks who are in our situation, don't let that discourage you. Don't let what's listed on the programs discourage you. Reach out, chat, and see what the program directors decide for themselves.
Yeah, I cannot agree with you more. We need to remember that especially big institutions, they all have lawyers and stuff, and they perhaps issue hundreds of those visas routinely. And although, as you said, it's not listed as an option, it doesn't require them a lot of time or headache to just go ahead and copy the same process for you. So as long as they like you, you have a good chance to get there.
Yeah, but that legal side of things was so smooth, and like I didn't have to do it at all. It's really just a matter of having someone be willing to do the sponsorship, everything else comes after that.
There is one more thing before we're gonna switch gears and pass the mic to Andrew. So there is also so-called, because we do see a lot of questions from actually international surgeons, those who have not completed. I think, well, some of them did complete steps, but some of them did not. Even when we post some postings of fellowships on AHC, for example, folks reach out from overseas and they ask, hey, can we come and get training? So in a few states, I know for sure in New York, but I think in some other states, there is so-called international fellowship process where you can actually apply to a fellowship, and I think you're getting some kind of limited license. So you're working like under, under the full license of your supervisor, but you can actually get a training and without finishing US residency. But I think you need to finish all the steps to do that. And after this, most of the time, folks will, of course, go back to their country, but they are able to bring that, experience and knowledge back home. So let's go ahead and, ask Andrew to share his experience.
So just a brief background for me, real brief. I come from California, born in San Jose, went to medical school at USC in LA, and then did my residency in Las Vegas for 5 years, general surgery residency. Then in my residency, nobody ever applied to MIS fellowship. There was one guy named Sean Suda, who's a foregut guy, like maybe 15, 20 years before me, who did. And that was just, I mean, nobody knew how he even applied. So I was kind of the first to trailblaze it and look into different types of MIS fellowships. I looked into all kinds of fellowships, and I think that's something that's really important to understand. The Fellowship Council doesn't really have the best instruction manual on how to apply or what to look for. You really got to know what you want. And so I think the three big pillars of MIS nowadays are essentially hernia or ab wall reconstruction, foregut, and bariatrics. And most fellowships have a mix of some of these. Very few fellowships are just single oriented. And I would really not discourage people from applying to the single oriented fellowships, but do try to vary things up, because the reality is in the job market, and maybe Ben can speak to this a little bit as well, it's very difficult to be a one-trick pony and to try to get a job. You have to know how to do general surgery no matter which one you pick. And honestly, mixing up some type of either foregut or bariatric with the ab wall recon is helpful. And I say that because my mentors also in fellowship, Dr. Carbonell, Dr. Cobb, all do foregut, right? Because the diaphragm and a diaphragmatic hernia and the eyes of a hernia surgeon is just another hernia, and they kind of treat it like a peristomal and fix it similarly. They do Bocchiolek hernias, Morgagni hernias, and all that type of stuff. So really try to vary things up, and I found that super fruitful. So I applied to Prisma Health. It was awesome program. Went in there for a year. We have two fellows, and we kind of split it up between the two fellows. 6 months of ab wall recon and 6 months of bari and foregut. But really, with just two fellows and 10 attendings, we kind of mix things up between us. So I did ab wall recon essentially all year, and foregut and bariatrics all year. And it's pretty important because the bariatrics, the foregut side, really taught me to be a good laparoscopic surgeon, whereas the ab wall recon taught me to be a good open abdominal surgeon and a robotic surgeon as well. The types of things we did in my fellowship, we did a lot of open TARs. Carbonell has done a total of 0 robotic TARs and 0 robotic ETEPs throughout my entire fellowship year. He does no more. He only does open. So with him, I did a ton of open TARs and reef stopas and crazy peristomals, and then with Dr. Warren and Dr. Cobb and Dr. Love, I did a lot of robotic hernia repairs, and did a mixture of a bunch: open, robotic inguinal hernias, ab wall hernias, peristomals, flank hernias, crazy hernias. We had perineal hernias from people with APRs. And the one thing that I told myself at the beginning of fellowship I was going to do, and I did a little bit, and I wish I did more, was to keep picking the brains of these hernia surgeons. Because in hernias, I've realized everyone is very strongly opinionated, but nobody is sure. And that's the reality of it. And especially with all the new instrumentation and sutures coming out, I remember within the first few months, Carbonell started using Duramesh. And I'm like, okay, why are you using Duramesh in this instance instead of PDS? And then sometimes they mix it up with Stratafix. And then sometimes they do permanent, and sometimes they do absorbable. And sometimes, I mean, it's just ridiculous how many new tools are coming out. And the reality is nobody's sure exactly when to use each one, and they're figuring it out. And the reality is they're much more experienced than I am. So during our hernia conferences, would put up slides of axial CT scans and ask Carbonell, Cobb, and Warren on the same Zoom call, how would you fix this? And even though this slide was of a CT scan they fixed 2 months ago, they would say they would fix it a different way based on that CT scan, just to pick their brain and see what they think on the fly. And it just goes to show, and it creates an awesome discussion. And I just wish I did that much more, because I only did that once a month when I had a chance. But every opportunity I took, I should have taken notes and done that more and more, because the reality is now you're kind of free and independent once you become an attending. And yeah, you can call them and they're always a text away, but it's harder to pick their brain when you're the opposite side of the country and you're not with them all the time. So that's the one thing I wish I did more. My recommendation overall, I am very happy with the fellowship I picked. I'm very happy with doing all three of them, even though I'm deciding not to do any bariatrics. Still happy I did it to gain the experiences that I did, and to know that I didn't want to do it, because that's something that I didn't know at the time. My residency never did bariatrics. And finding a job for me, my co-fellow was looking for just a hernia job. I kind of was more open to abwal, foregut, and general surgery, and I had a little bit of an easier time than she did. I think it's also very important to know if you want to do private or academic, because that also dictates your job pool and what you're looking for. And so I knew I wanted to be academic from the get-go. And so starting early throughout the fellowship and getting those feelers out was important. So that's my 5 minutes.
That's awesome. Thanks, Andrew, very much. So, we have just about 15 minutes left. So I really want to use this time to pick, Dr. Blake's and Dr. Belyansky's brains on really how do they assess, evaluate the applicants, right? So do you guys use some kind of more holistic approach and just looking at a little bit of everything? I know it's, you don't have to, share what you can, right? But I'm just really curious, how does it work? So do you have any certain cutoffs, right? Do you look at AppSite scores? Do you look at the letters? Do you reach out to letter writers perhaps? Do you, evaluate like how this person actually is a hernia enthusiast, or, they're just kind of applying a little bit of everywhere and they realize that bari volume is going down. So they try to figure, should we just do more foregut or, abwal? Do you look for electives, right? Do this applicants, have any dedicated electives or research time, perhaps? So how does this work? Like, what's the just really what are your thoughts on that?
I guess I can go first real quick, and then Dr. Belyansky, you've had way more experience with this than me, so you can go next. But yeah, so we had our first fellowship was this is our second year actually of our fellowship. The first year we just finished up and it was unaccredited, and now this year we are in the fellowship council. So this is now our second year to have a hernia abwal fellowship. And we have two, it's similar to the Greenville group where we have a group of like bariatric foregut specialists, and then we have me and my other partner, Dr. Aldo Fafai. He trained at Cleveland Clinic. We're more of the hernia abwal, and we also do foregut. So it's similar to the Greenville group, but a little bit smaller. But the biggest thing I've been looking at for the last 2 years looking at these applicants is I'm trying to figure out what you all want. And kind of like you said, I think Ben, you said it earlier, like just be true to yourself. So if I know exactly what you want, then I can figure out if you're a right fit for our program, because I know what our program has to offer, and so that will help a lot. But after that, once we know that we're looking for the same thing, that's super helpful. So just being truthful and honest. And then the next thing is everything you said, Artem. So letters, yes. AppSite, yes. I mean, it is getting competitive, and so if you're struggling on your AppSite every year, it's getting competitive. So we need to know you're going to pass your boards during your fellowship. So I do want to see that. And then letters from people who I recognize in the field and I trust in the field are super important. And yes, I am reaching out to the letter writers for the people who are more of a serious match. So Dr. Belyansky, tell us your secrets.
Ah, so I think when you apply to each fellowship, you just kind of gotta figure out what kind of model there is. There's so many different fellowships. Like for example, like Andrew, like yeah, I'm gonna keep picking you because I know your fellowship very well, but there are like about 4 or 5 guys you work with. You know, Artyom, for example, he works with at least when he did his fellowship, he worked with really 3 guys there, but really 2 of them. In our fellowship, you essentially spend like 85% with me. So if you think you can get along with me, you shouldn't rank us. You know, it's just like it's really truly perceptorship model. And by the way, listening in is Dr. Lindsay Nazarek here. She's listening in, but she's our current fellow right now. If she wants to say a word, please. She's welcome. You can ask her like what it's like to be our fellow here. So, you know, what do I look for? I look for, to be completely honest, somebody who I think I can work really well together with for a year. What I look for in a fellow is somebody who, you know, I think those of us like right now who are starting out, who have fellowships, AWR fellowships, I think we have a responsibility specifically to look for people who are going to be teaching others. That's one of my papers. You don't have to be necessarily in like Ivory Tower Academic Center. You can be in a community residency program. You just want to, or you want to build your own fellowship program. And then also I look for builders, people who are gonna want to start their own center and kind of build a program. So people who are gonna contribute to the field. So I'm gonna spend a year of my life investing in that person. And I want that person, the way they can pay me back is by paying it forward, by going to the community of their choice, building a program there, and hopefully teaching. Because otherwise, if not teaching, the knowledge it has to be exponentially expanding. They're going to teach their own fellows. I'm going to continue teaching my fellows, and it's just going to expand. That's how kind of this curve is going to is gonna hurt. My kid here is like making faces here, so I'm getting distracted. Anyways, the point is we want to make sure we pass on the knowledge. You know, is there a particular upside scores? Sure, you have to be able to pass, but you know, like I'll do a screen. Like one of the reasons I left Fellowship Council is because we were getting over 100 applications, and this is like probably everyone is getting 100 applications now, or even more. And I had to sit down and spend hours and hours reviewing them. What ended up happening, especially now, like all the interviews now are basically online, is people would just like shotgun apply to MIS fellowships, and you know I don't blame them because you know it's getting so competitive to get in. I was actually surprised like how many people I matched. There's some people that I really liked, and I would have like. There's a person who I ranked #2 last year, and I got my #1 pick, and he didn't match anywhere. It was really sad to see that happen, and it's really competitive. And so um, it's you want to make you want to make sure that you want to make sure to make an impression on someone, but really at the end of the day, it's about, I think for me personally, it's somebody that I can spend a year with or working with. As far as research is concerned, do I look for research? You know, like all of that, like you know, we all know, like all of that's a paper filler. So, you know, not to take away anyone who has spent 2 years doing research. It's important to me, but at the end of the day, if I feel like that person and I are not going to be able to work together, it's just not going to be a match. So the reason I left Fellowship Council personally, this is actually second or third year we're interviewing, kind of, is to decrease the number of people. That are applying, so actually less people know about the program. I'm happy with that. I usually like the first time I went away, I only get 10 applicants. I ranked 5. I got my #2 pick, I think, or #1. Last year, I actually got like 27, so they went up quite a bit. So we had to do some work. We interviewed, I think, 15 people, and we were able to essentially offer a spot to someone within a few weeks after. So I'm going to continue going outside the match because It's just, to be honest, it makes my work easier and I don't have to interview. It's very hard to figure out initially on paper. And when I was looking at it, I'm like, you have to want to do AWR. So like, again, I'm going to push back at Andrew. Every one of my fellows right now is somewhere an AWR specialist. So we had no problems placing them. So last year, Ian Bassi, who did the fellowship with me, he's actually my partner now. We hired him, but he interviewed at Mayo Clinic. And the funny thing is, he interviewed Mayo Clinic, and the person they picked was a Yuri Nowitzki's fellow. So that's kind of, but like, so there are a lot of, I get phone calls all the time to see if they're, fellows that kind of are looking for jobs. This year's fellow, Lindsay actually potentially has a job in California. Specifically, she came to do a fellowship with me because they wanted somebody to run or start an AWR center. Like the West Coast is really up for the taking. There's several people there, but there's a lot of potential opportunity in the West Coast to do AWR. So I don't know. I hope that answered the question. I'm kind of like, for me, it's a feeling thing. I have to feel it. It's just the way I picked the fellowship, like pick Hanford, it just worked out right. It's just the same thing. You can have completely empty CV. And if I like you, I'll pick you over anyone who is a very, and that's just me. That's not everyone, by the way. That's me.
Yeah, that's perfect. Dr. Bronsky, sort of like one quick thing. So in terms of this, vibe thing, right? So I know that all the interviews now on Fellowship Council, they're all virtual. So how those folks who interview through Fellowship Council, how do you actually use this, 10, 15 minutes of interaction, screen interaction versus in person? Because I think you interview in person, right, Igor?
Yes. So we last year we actually did not interview in person, and part of the reason is to be honest, I had an insight. So we had Ian Babasi, who I mentioned, he was an internal candidate. So that year I did not interview anyone. Last year I had actually three residents rotate with me, and then I also had our fourth year applying so an internal candidate who I knew very well, and actually I knew him since high school. He was a research high school student with us in 2012. So his name is Kevin, and so I wanted to interview. I give everyone a chance, and I honestly didn't know, but I also felt like I was probably going to go with Kevin, but I really want to give it. So I didn't want people to pay out of pocket to come and see me. I felt like, so last year, I decided to do it. But yes, it's an in-person interview for me. So this year, we're going to, again, offer an in-person interview. I just really want to get a feel for a person. I want them, if they're interested, they're going to come. If not, that's okay. I mean, all 100%. I need to interview is 3-4 people and offer one spot.
Dr. Blake?
Yeah, I was just going to reiterate, same thing. Like, if we can't get along for a year, no matter what your CV looks like, it's just a no-go, definitely. And yeah, I 100% agree too. I see a ton. I'm on Fellowship Council for the first year, hundreds of applications, and half of them don't even say ab wall or hernia in like the personal statement. So it's like, you gotta want this. And I think everybody on this call wants it, otherwise you wouldn't be here. But yeah, that's a good point, Dr. Belyansky, about just getting out of the Fellowship Council, because there are a lot of people that don't know what they want. And I need to know that this is what your passion is. This is what you want to do. And yeah, you want to go be a leader in the field, because we're about to spend an hour of our time and effort on you. And we want you to, pay it forward and expand the field. Totally agree with those points.
And we don't have signals like in residency. So if you got 100 applicants, they all applying everywhere.
Mm-hmm.
Yeah.
All right. So
match is it's a tough thing. Can I just say a word about the match and why the match was started? So we may start seeing this, those of us because what happened back in the day when there were multiple programs outside the match, and this may start happening. And so say, like what Yuri and I do behind the scenes is we try to offer at the same time. We try to talk. So some of you guys may not know, but Yuri and I talk all the time. Like those of us who are outside the match, we talk between each other all the time. We know all of you guys. So it's kind of like we discuss you guys, and we're like, okay, well, listen, I'm going to offer this guy. You're going to offer this guy. Okay. But as the programs expand, the number of programs, what's going to end up happening, we're not going to be in sync. And I'm going to offer you a job. You're going to say, okay, you signed the paper. And then last minute, somebody else is going to offer you a job. And you didn't want to be with me. You want to be with that person. You drop me off. And then I don't have a spot. That's what was happening in 1990s. That's why Fellowship Council was started. And I think we're going to have to go back to them. I'll probably eventually will have to go back to the match, potentially, when there are more and more programs. Right now, I can get away with it. I did it because it was easier. But what I want is it's more of a focus. I want, if possible, I don't want to be under MIS. I want to be under AWR fellowships. Let's make it less people, and let's really truly make it for people who are interested. But we're not there yet.
I agree with that. That'd be wonderful.
Yeah.
We need a special hernia match because, this is happening already, what you mentioned, Igor. So I do feel that right now we have, about 17 fellowships, I think, in our directory. And so at some point, probably we'll end up actually making a separate match process, not under the MIS umbrella, but a separate altogether.
How many are outside the match? Because like me, Yuri, is it?
I think there are
I'm
9.
not sure if Hannaford has a fellowship. Who else?
Well, there's a good.
Cleveland's in the match. Cleveland's in the match. Carbonell's program's in the match. My program's in the match. We're brand new.
Yeah.
Some of the ones that we have on our list outside of the match include Houston, Oregon, Stony Brook with Artem, Milwaukee, all programs outside of the match. And maybe in a couple of years, or maybe in the incoming year, we're also going to see some international fellowships, because something to keep in mind, there are fellowships and European fellowships as well that folks can consider.
Is is your program in the match or out of the match?
In the match. When I matched, when I applied rather, and accepted it, it was outside the match for the hernia position. And then after, like my fellowship afterwards was within the match.
And so a word about being like applying to like a program outside the match. What we do is we offer interviews around the same time, but we try to make sure you commit to one of our programs before you have to finalize the list. And if you don't want to go with us, it's okay. We'll offer you a spot, and then what my program does, we give you an offer letter, so make it an official. So you have a document at least from our like C-suite that you are hired now as a like whatever year you're hired for. So it's all legit, and then the people who are accepted then drop out of the match, and that's it. So you don't go through a match.
Well, I think it was excellent discussion. Do you guys have any more advices, and do we have any more questions from the audience to our panelists? If anything, last minute, please go ahead and put it in the chat, and we'll bring it up. And actually, Margie, that's awesome that we're gonna have the recording as always, because I actually had also a couple of folks who currently are in Europe and cannot attend. All right, so we have a question. Thoughts on job market? So excellent. Thanks, Taylor, for bringing this up, because I actually had this in my to-do list in the questions. So that will be probably more of a question to Andrew and Ben. When did you guys start to look for a job? What websites did you use? Is it just word of mouth in your experience, or did you look for like SAGES, Society of Surgery and Parliamentary Tract, AHS job board, or just perhaps Google as an aggregator? I found my job actually through AHS / word of mouth, but what advices? And then probably we can also pick Igor's brain and Kayla's regarding what's the current landscape, and do we expect that we're going to see the growth of abdominal wall programs in the country, and once the realization comes to the department chiefs and chairs that there is a need in the community for a dedicated ABL surgeon, that they're going to start offering more and more dedicated ABL spots.
I'll try to be quick about what my experience was. In short, I think that the hernia job market will continue to grow and grow, both academically and community. I think certainly in the community it will blow up. Academic is always a little bit about timing politics, but it's there. I think foregut is like there's always going to be a need for foregut, and I saw a ton of need for foregut. I think bariatrics, as we all recognize, is declining. If you're looking for like, I think that having hernia is a big part of your narrative, and this is what I found. And just purely in your clinical interest was extremely helpful to the job market. But the one thing that I would take away, and this is what I saw personally and otherwise, is just be an excellent surgeon and an excellent doctor, an excellent colleague, and that dictates your job market more than anything else. And that when you are an excellent surgeon, an excellent doctor, an excellent colleague, and you're very clear with what you want, you will find a job somewhere, and you will find the job that you want. And the word of mouth job market, like Dr. Belyansky is talking about in terms of the texting, folks calling known programs and say like, hey, do you have someone graduating soon because we want to hire a hernia person? That is probably where most job opportunities exist. Like there is the indexed job markets in terms of Google searches and IHCs and Sages or whatever. And then there's the non-indexed job market. And the non-indexed job market is huge and helpful. And the way you access that is just to be a good person, a good surgeon. And that matters the most. So your reputation, your work ethic, that will bring you, like that is what opens doors, I think.
I think that academic jobs are significantly harder to find than non-academic jobs. I think non-academic jobs, especially if you're focusing on hernias and ab wall reconstruction, is actually quite easy because why would a private hospital not want a general surgeon who's also specialized in ab wall recon versus just a regular general surgeon? I think it makes you, it's just like getting an MBA in most jobs. It's just an extra sweetener to get you a job and it's much easier. Academic jobs, I think, are quite difficult, and I applied quite broadly. I think so. I used Sage's job website. The Fellowship Council one kind of sucks, and quite honestly, all the other websites are not really that updated. And then Google, as Artemis said, is actually quite helpful if you type in the location you're looking for. But if you're looking to do academic, your geography preference has to be almost non-existent because if you're looking to only do California or only do Florida, and academic, I mean, you got like 3 or 4 spots, and if they don't have a spot available, it's over. I mean, there's nothing else you can do. I think in general, academic positions also are either looking for somebody that's already experienced or somebody that they know quite well. So whether you are a resident there, a fellow there, or somebody there knows somebody that you're working with quite well in internal contact. Otherwise, it is very difficult to break through the academic market, in my opinion. But I agree with what Ben said. Of the 3 specialties, if you can do ab wall recon rather than just focusing on barrier or foregut, that's your best shot to break in. But academic overall is challenging unless you know somebody in that area or you're experienced. So I did residency in Vegas. Basically, my 5 years there were a job trial. They absolutely loved me. They offered me a job when I went to fellowship. They said, when you come back, look. And then I looked at all the jobs in California, and it's funny, like all these academic institutions, they put job postings up every year, but then they don't get filled. Like the Mayo job posting has been 3 years in a row, and I don't know if they finally filled it or what happens, but then they take it down and re-put it back up every year. Like UCSD, UCLA, UC Irvine, they all have job postings and they all hire somebody 3 to 4 years experienced. But it's tough. It's tough, but once you get in, you're in, and then it's easier from that point on. So.
Yeah, it has a lot to do, I feel like, with the academic market. It just the relationships and who you know. Like, yeah, I think that's the biggest part. The first fellow that we had last year that created the fellowship, Oshner Clinic, they wanted an ab wall specialist, and we happened to know the same people, and it just worked out for it to all happen. So it was all like who you know, and they hired her before she got back. They like made her sign the contract. So it was very much just like, yeah, networking. Otherwise, I do feel like it's probably pretty hard to break into the academic sphere.
Well, that was I think absolutely terrific hour. Thanks everyone for attending, and again for all the trainees, spread the word, sign up for Hernia Olympics, sign up for Jeopardy at AHS meeting. It's one of the opportunities for you guys, to distinguish yourself and really FaceTime with your potential, boss perhaps, and just come over to AHS to Nashville, and it would be great to see you on the reception and perhaps on Jeopardy and Olympics. So with this being said, we're gonna close this webinar. Thank you so much, Margie, for making this happen. For the recording, thank you so much, Dr. Belansky, Dr. Blake, and Ben and Andrew for being here today. I know it's late and everybody's tired, but that's very important that we're raising the awareness and answering those questions. Thank you, guys.
Best of luck.
Thank you.
Good night, everyone. Thank you so much.